MD Conference Live presents updates from the American College of Cardiology meeting in Orlando, Florida.
We did find that there was a significant 43% reduction in the occurrence of VTE associated with rosuvastatin. Effect was comparable in the events that were triggered, occurring in the context of surgery, trauma, or cancer, and in those that were out of the blue, spontaneous events. 90% of the VTEs occurred in people who didn't have a cardiovascular event before that during follow-up. So this was an independent effect of statins. And when we put it all together and talked about the net benefit, and when we go back to you're having this conversation with your physician, the physician can say, well, if we take a wider treatment target for statins and add in venous thromboembolism, then the risk reduction is consistent for VTE. The number of patients I need to treat goes from 25, which is already pretty remarkable for 5 years, to 21. There's a 22% increase in the net reduction in events. And if we take a wider target and also include death, then the NNT further declines to 18. This was a sub-study in the Jupiter trial, and we found that the people who were randomized to receive rosuvastatin had a 43% reduction in their risk of venous thromboembolism through the duration of the study.
And that's an interesting new analysis. We've seen statins used in coronary events and even in stroke, but does this suggest a new role for statins in venous events?
It does suggest that. Now, it's a common event, but perhaps not common enough to warrant primary prevention for statins. But the result then should be viewed in the context of statins preventing not just coronary events, but also strokes and venous thromboembolism as well.
Very interesting. And how do you see this impacting clinical practice?
Well, when patients visit their doctors for advice about lifestyle and medication approaches to prevent these diseases, that venous thromboembolism should be part of the discussion. It's a big, important disease. And now doctors have something that might help. So perhaps it wasn't part of the discussion before because there was nothing they could do about it from the primary prevention perspective.
And so physicians might want to consider adding statins to a larger demographic of their patients?
Well, when they make the decision, and the decision should be driven by the risks of arterial events primarily, but this is another benefit that they would get from this. They should consider the total target of, as for any therapy, what are the potential totality of benefits that might accrue.
And will we be seeing future studies analyzing this venous effect of statins?
Oh, of course, yes. We'll need to do more work to elucidate the mechanisms of whereby the statins prevent venous thromboembolism.